All right, well, welcome to my presentation. Today I'm going to be talking about glaucoma eye disease and specifically looking a little deeper into the neuropathophysiology of glaucoma and how that affects the blindness aspect of glaucoma mechanistically. All right, so let's dive right in. By way of introduction, we will be going through these different points, looking at the epidemiology, the etiology, some of the mechanisms and anatomy and physiology related to that, and then talking briefly about the symptoms and treatments, and then prognosis. So glaucoma is a disease that in 2020, it was estimated that more than 57 million individuals were affected around the world. And I really think that's a pretty large number. And mind-blowingly, it's supposed to be over 110 million by 2040. I think that is very scary. That's individuals who have the disease. So that is rough for them. I think, though, it's most important to understand the risk factors because not only do we not want to get the disease ourselves, but we also want to be able to advise our patients. And so, if our patients are having some of these risk factors, we want to be aware of that so that we can advise them accordingly. So, for example, some of the most significant risk factors would be, number one, age. So if someone is over the age of 60, they are automatically at a higher risk for developing glaucoma. Obviously, that's not the only risk factor. That's not the only thing. Obviously, not everyone over 60 has glaucoma. But anyway, there's also severe myopia. So when you have a severe nearsightedness, you are at a much higher risk for developing glaucoma. For many reasons, but primarily it has to do with the angle in the anterior portion of your eye, and that is where the drainage system for aqueous humor is in the anterior chamber. And when you have a severely myopic eye, then when your eye is accommodating in things, your eye narrows that drainage system, and therefore it essentially raises your intraocular pressure, which we're going to talk more about that. But here's another risk factor, elevated intraocular pressure. So that is one of the most highly targeted things as far as treatments go. We're going to talk about a little later. Some other risk factors that are also significant, but maybe not quite as significant, would be smoking, race, especially those from African descent. For some reason, the anatomy of their eye is such that they are at higher risk. Chronic blood pressure changes, some vasospasming, and also if you use steroids systemically or topically, it does put you at a higher risk for developing glaucoma. Now, the cost of glaucoma, someone with glaucoma, what kind of a cost burden does this add to them? So it's estimated that around somewhere between $200 to $1,200 a year is in addition for these medications, treatments, surgeries, et cetera, on average. And that might not sound like a lot, but we already talked about the other risk factors. We're going to talk about some more in a little bit as far as maybe other co-conditions that you can have along with it. And so a lot of these people that are at higher risk for glaucoma have other conditions they're already dealing with and treating. And so to add this on top of that just adds actually, I would say, somewhat significant financial burden to them. And so I think that is really sad. Now, let's dive a little bit into the mechanisms of how this disease actually works. So there are multiple theories that surround the neurodegenerative part of glaucoma. So essentially, glaucoma is a disease that is neurodegenerative, and most of that neurodegeneration happens in the optic disc, and you can see the optic disc there. And that neurodegeneration causes a thinning of the tissue in the optic disc. And so there are retinal ganglion cells all throughout the retina, and they project their axons, they travel through the retina, and then they exit posteriorly from the eye through the optic disc and into the optic nerve. And surrounding your entire eye, you have the white part of it that's called the sclera, and it's a very fibrous structure, very strong. that helps maintain the round globe structure of the eye. And there needs to be an opening, though, for the axons of the retinal ganglion cells to exit the eye into the optic nerve, as well as the vasculature to enter and exit the eye. So the sclera is not able to have that happen, but there is a structure there that is porous called the lamina cribrosa, and that spans the opening of where the optic disc is. So just posterior to the optic disc, you'll find the lamina cribrosa. Now, the lamina cribrosa is a very mesh-like structure. You can see here that it's very porous, but very strong and sturdy. Though obviously this is very magnified, and so these in real are very, very tiny openings. It does help to, allow those nerves and vasculature to pass through in and out of the eye, et cetera, as we already mentioned. But one of the things that we just already talked about was the risk factor of elevated intraocular pressure. So how does that work? Well, in the anterior chamber of your eye, you have a fluid called aqueous humor, and it's secreted there and it's drained there. And so there's a little bit of a flow. It helps provide nutrients to the avascular portions of the anterior chamber of your eye. All that aside, when you have an oversecretion, it can raise your intraocular pressure. When you have a decrease in the drainage system, maybe a partial blockage, maybe a total occlusion, et cetera, you have elevated intraocular pressure. When you have an elevation in your intraocular pressure, it will put a pressure towards the posterior part of your eye. There's a fluid there as well, called the vitreous humor in the posterior chamber, and that's going to put a pressure on the back part of your eye, and that is going to put pressure on that region where the lamina cribrosa is. Really, it puts pressure on your whole eye. Your sclera is totally fine, though. You're chilling. But the lamina cribrosa, remember, is where all the vasculature leaves and enters the eye, as well as your nerves. And so that is very porous, as you can see in this picture. And when you put a compression against that, against the cerebrospinal fluid that is pushing up against the other side of the lamina cribrosa and the sclera, et cetera, it compresses it. And when it compresses it, it narrows those openings in that mesh work. And when that happens, you get some decreased or compression of those axons and the vasculature, which can lead to ischemia and apoptosis as well. And and that happens because of a decrease in action potential propagation. So when you have a, let's say, for example, just a constricted axon, you're going to get a decrease in sodium flow and propagation down the axon when an action potential is attempting to propagate down the axon. And when you have that, it is going to decrease the action potential propagation, which will then lead to, according to research, they are showing that can cause ischemia and also apoptosis. So now the ischemia also can be accentuated and made worse based on the different compression of the vasculature as well. So let's talk about vascular dysfunction. This is another big one, and it still has to do with the neurons. But interestingly, the vasculature that supplies the blood to the neurons and the nutrients and oxygen and so on plays a big role. And it does so by maintaining a constant flow, a constant supply of oxygen. By so doing that, the neurons and their glial cells surrounding them, they help to maintain a homeostatic environment. And they accustom to that, and so therefore their mitochondria are functioning on that the way they should. However, when you get a big fluctuation, their mitochondria don't know what to do with that, and they start producing reactive oxygen species, ROS. So there's two different types of vascular dysfunction that we'll talk about, primary and secondary. So PVD is when you have a vascular dysfunction in an otherwise healthy individual. There's no other conditions that are contributing to that. And it causes blood pressure fluctuations. and that can be systemic, locally, et cetera, but it causes those fluctuations. And it does so by causing an abnormal release of the local hormones that affect the vessel tone. So it can cause a constriction, it can cause a relaxation, but it's an aberrant. So in other words, suddenly the homeostasis of it is lost. And so therefore, patients that have a PVD are even greater susceptibility to elevated intraocular pressure because it further reduces the fluctuation and it reduces the blood flow and causes more fluctuation. Secondary vascular dysfunction is caused maybe by diseases like arteriosclerosis and MS, things like that. But those types of diseases put people at a higher risk for glaucoma. Some symptoms. So glaucoma is very difficult to diagnose because it's painless usually. Also has a very slow progression, so people often don't notice it. So people need to go in for regular eye checkups, make sure that they are healthy. They need to have a dilated eye exam periodically to make sure that their optic disc is healthy, a healthy thickness. They can even have tests done like this RNFL OSCT, and they can check the thickness of your neural tissue at your optic disc. Acute glaucoma can happen when you get sharp pain in the eye, sometimes and often involved with a headache as well. Can turn into nausea if it's bad enough, and light flashes as well. Treatments, first line is eye drops to reduce the intraocular pressure. That's a number one way. Second, they go for is a laser to either create a new drainage pathway or allow more fluid to exit through a innate drainage pathway. Currently, the vision loss from glaucoma is permanent, but there are some future treatments that I'm really excited about. There is gene therapy that's in trials. Some of the gene therapy is geared towards neuroprotective, so it's helping to protect the retinal ganglion cells from the intraocular pressure elevation and things like that. So that's great. I'm excited about that. But more importantly, that I'm excited about is that they have actually been able to successfully restore vision in mice that have lost it from induced glaucoma. So I'm super excited about that. Obviously still in trials. I don't know exactly where it's going to go and how long it'll be until they can roll something like that out. Very exciting things though. The prognosis for these patients is really not great. If they go undiagnosed or untreated for too long, it's just going to result in blindness. And sometimes even if they do get treatment, it'll still result in blindness. But long-term treatment, they're also going to be on daily eye drops, mostly, and sometimes several. And often they're going to undergo one or multiple surgeries throughout their lifetime. And very, very sad. Very difficult. No one loves to put drops in their eye. No one loves to get surgeries in their eye and have a poor prognosis, realizing that this is just leading to blindness. So very sad. So to wrap things up, glaucoma is one of those leading causes of blindness, and therefore I think it really warrants that we put more effort, more resources towards understanding treatments for it, especially some of these gene therapies. I think that we ought to push those. Most of the current treatments are just really prolonging the inevitable, but thankfully there are some more things in line with these genetic therapies. I'm really thankful for that. Super excited for the future in this. But yeah, that is glaucoma in a nutshell. That is some of the mechanistics behind the vision loss and how that affects the neuropathophysiology. Here are my references, and I hope you enjoyed the presentation.